Dear all, welcome to this Nephrotube lecture. This lecture is about IgA nephropathy, and I will stress on KDIGO 2021 Clinical Practice Guidelines for the management of IgA nephropathy. As I always say, our lectures are available as videos on our YouTube channel Nephrotube. The PowerPoint is available at nephrotube.com, and please join our Facebook group, follow our Facebook page and Twitter account to see the activities done by our team. This is my talk outline, and I will start by talking about pathogenesis of IgA nephropathy. At first, I will talk about the normal formation of IgA and the normal pathway for the activity of IgA. Actually, we have two subclasses of IgA produced by plasma cells. Plasma cells in GIT and respiratory tract form IgA1 and IgA2, while plasma cells in bone marrow, lymph nodes, and spleen form IgA1. And as I will say in the next slides, that IgA nephropathy is due to abnormality in IgA1. Normally, IgA is the principal antibody that plays a critical role in mucosal immunity. So if you have any mucosal infection, GIT, respiratory, the antibody that will be formed and has a critical role for immunity is IgA. So let's suppose that this is epithelial cells of any mucosal structure in your body. This is the lumen, this is the plasma cells. When there is infection in a mucosal area, plasma cell will produce IgA antibody that will attach to what is called poly-Ig receptor, and at this time the IgA antibody is called polymeric IgA. Then it will be endocytosed by endocytosis, then exocytosis again, while it is attached to what is called the secretory component to be secreted from the epithelial cell, and at this point it is called secretory IgA. Then it will attack the foreign antigen. This is the same idea. Here the B cell in the submucosal area produce what is called polymeric IgA that will be secreted attached to a secondary component called secretory IgA. Normally also IgA clearance is through the liver. So as I will say later, any liver derangement or liver abnormality or disease may cause the decreased clearance of IgA with accumulation of IgA causing IgA lesion. This is a normal structure of IgA. I will not go in depth for the normal IgA1 structure, but I want you to see here what is called hinge region. This area is called the hinge region. And in picture B, this is the classical shape or structure of the hinge region. This is a normal one. In abnormal IgA, there will be abnormality in the hinge region. There will be under glycosylation. Under glycosylation for this part, there will be reduced galactose or reduced sialic acid content in this part, causing abnormal IgA, and this only in IgA1, because IgA2 has no hinge region. So the abnormality in hinge region that will cause IgA nephropathy will be only in IgA1. Also, IgA1 may be accumulated in inappropriate form, as I said, if its hepatic IgA clearance is reduced. Let's see the overall picture of IgA nephropathy and how IgA will be accumulated in the kidney. At first, hit one, as I said, that there is abnormal under glycosylated IgA. So the IgA now is abnormal, is a self-antigen that will be attacked by antibodies, autoantibodies. Then both of them, antigen and antibody, will circulate in the bloodstream. Then this immune complex will be trapped finally by the kidney, the glomerulus, causing local inflammation, local activation of the complement, and local inflammatory mediation, causing finally glomerular injury. So this is the final shape, or the whole pathway in 4 steps, describing why IgA nephropathy may be happened. Okay. Let's now talk about clinical presentation, how IgA nephropathy can present. IgA nephropathy can present by macroscopic hematuria, about 14%, 40% to 50% of the cases. Asymptomatic hematuria and with or without proteinuria less than 2 gram, from 30% to 40%. Nephrotic syndrome, 5% of the cases, and usually it will be associated with minimal change disease. It may be associated with acute tubular necrosis because of heavy bleeding in IgA nephropathy. Red blood cells may be accumulated in the tubules, causing acute tubular necrosis, or maybe crescentic IgA nephropathy, and finally, as any pathology or any glomerular disease that may cause chronic glomerulonephritis and be a cause of chronic kidney disease. Regarding the pathology, I will go rapidly through the pathology. Here there is mesangial proliferation, IgA nephropathy. IgA deposits mainly are in the mesangium, causing mesangial proliferation and mesangial expansion with many cells in the mesangium. Here is another shape, mesangial proliferation and expansion. Here is tubules with occluded tubules by red blood cells, as here, with heavy hematuria causing acute tubular necrosis. This is regarding light macroscopy. Regarding immunofluorescence, for sure we will find diffuse IgA deposits and C3 deposits in 90% of the cases, while C3 in the serum will be normal. In idiopathic IgA nephropathy, C3 in the serum will be normal. It is deposited in the glomerulus due to local activation of the autoimmune system in the kidney. It may be associated with IgA, IgG or IgM, and also maybe kappa and lambda chain. This immunofluorescence staining for IgA, you can find that the stain is localized in the areas of the mesangium. Here's the same localized areas of the mesangium giving the immunofluorescence light. And this is the electron microscopy deposits. Okay. What about the treatment? First of all, you have to diagnose your case correct. What I mean, not every IgA deposits in the kidney equal idiopathic IgA nephropathy. Again, not every IgA deposits in the kidney equal IgA nephropathy. Let's see what I mean. If you find IgA dominant glomerulonephritis, you find a pathology in the kidney with dominant IgA. First of all, you have to exclude the presence of IgA vasculitis. IgA vasculitis is the same as Henriksen-Lime purpura. You have to find if there is extrarenal manifestations of these IgA deposits or not. If no, so it is localized IgA, idiopathic IgA. If there is systemic manifestations, other organs affected by vasculitis, so it is called IgA vasculitis. This difference or this differentiation is important because it will affect how you manage the case. Second point you have to exclude if there is any secondary cause of IgA, viral, HIV or hepatitis, inflammatory bowel disease, autoimmune disease, liver cirrhosis, because with all of these diseases, there is abnormal formation or abnormal accumulation of IgA nephropathy. And finally, you have to exclude IgA dominant infection related GN, and it is very common with staphylococcus infection in diabetic patients. So you have to exclude the presence or the evidence of the presence of infection because the management will differ. So if you have IgA dominant glomerulonephritis and you exclude all secondary causes, so now you can say it is idiopathic IgA nephropathy. Once you diagnose it as idiopathic IgA nephropathy, you have or already the pathologist did this job, scoring the kidney biopsy according to the MSC score, the M for mesangial hypercellularity, E for endocapillary hypercellularity, S for segmental glomerulosclerosis, T for tubular atrophy, interstitial fibrosis, and finally C for the crescents. The higher the score, the more the bad prognosis of the case. This is the scoring of the biopsy, and you have to risk stratify the patient according to what is called the International IgA Nephropathy Prediction Tool that predict 50% the risk for 50% decline in GFR or progression to kidney failure up to 6.7 years. This may affect your decision for treatment and affect the patient shared decision making with you regarding to use immunosuppressives or not, according to the risk of progression of the case. And then if there is priority to involve your patient in a registry, this is a registry, so this is fine. And finally, now you have idiopathic IgA nephropathy. You have to start and to optimize supportive care by blood pressure management, use maximally tolerated dose of ACE inhibitors and ARBs, adjust the lifestyle modification of the patient, and address his cardiovascular risk. Okay, then for how long I will continue the supportive therapy? If you still have proteinuria more than 1 gram per day despite at least 3 months of optimized supportive care, then you have to think about second step. But if you get proteinuria less than 500 milligram to 1 gram per day, so you may consider this as a partial remission or a remission. An important point was the target of blood pressure in these patients. The target of blood pressure is less than 120 millimeter mercury. Okay, so if the patient after 3 months didn't respond to the management, the patient still has proteinuria more 1 gram per day despite at least 3 months of optimized supportive care. If there is a possibility to enroll the patient in clinical trial, so it's okay, then you have to ask yourself what is the GFR of the patient. If the GFR is less than 30 ml per minute, so consider supportive care, maximum supportive care, no immunosuppressions, just follow your patients for the progression of the case and for the preparation later for renal replacement therapy. If the GFR is more than 30 ml per minute, so you have to consider with your patient the risk and benefit of the use of glucocorticoids, to use or not to use. And there is important point here that patients enrolled in one large randomized controlled trial suggesting benefit only of the immunosuppression only or mainly in the patient with an average of 2.4 gram per day of proteinuria. Here is from where the evidence had come. Usually the patient who respond to glucocorticoids, those who have average proteinuria of 2.4 gram per day. Okay, but important point, before considering glucocorticoids, you have to assess the risk. Because you will give steroids, and this point is generally used in all glomerulonephritis disease. If the patient is diabetic, obese, the patient had latent infection, secondary disease as cirrhosis, peptic ulcer, uncontrolled psychiatric illness, osteoporosis, you have metabolic syndrome, advanced age, so the risk of osteoporosis will be high. So you have to balance the risk and benefit of the use of glucocorticoids before using them. And for sure, for any patient who you will use prednisone equivalent or its equivalent more than 0.5 milligram per kilogram per day, the patient must has prophylaxis against pneumocystis pneumonia along with gastroprotection, bone protection, according to your local guidelines. What if I decided to use glucocorticoid? What is the dose? We have 3 regimens according to 3 different studies. All of them, the total exposure is about 6 to 8 months. All of them, you will start by a dose for a certain time. Then you will taper this over the total exposure time after you make a risk-benefit balance. Okay, so you will start dose for a certain duration, then you will taper the rest of the duration. An important point to the second time that we'll concentrate about it is this approach is acceptable for all IgA related renal diseases? The answer is no. This approach is only for IgA nephropathy, idiopathic IgA nephropathy. So this approach is not applicable for IgA nephropathy with rapidly progressive glomerulonephritis, IgA nephropathy with crescents. It is not acceptable or not applicable for IgA with acute kidney injury secondary to hematuria and AKI. In these cases, we will have another way of management. It is not acceptable if the case is IgA deposits with minimal change disease, because this case will be treated as minimal change disease, as I mentioned. This approach is not applicable to IgA vasculitis as an action line purpura that has local kidney IgA nephropathy. Beside it, there are other extra renal manifestations. It is not applicable, this approach, for secondary IgA nephropathy. It is not applicable for IgA secondary to infection, post-infectious glomerulonephritis. In these cases, you will treat the infection and you will treat the secondary cause. Here are some specific points. We know in the past guidelines that tonsillectomy shouldn't be performed to treat IgA nephropathy, except in Japanese. In Japanese, considered tonsillectomy, there is a good evidence that tonsillectomy in the Japanese has a good effect in IgA nephropathy. And also, special situation for the Chinese, you can use MMF instead of glucocorticoids and get a good response. So MMF, mycophenolate mofetil, can be used as a glucocorticoid sparing agent. Another point that I have to stress, beside what was mentioned in the KDIGO guidelines, is that we now have a very good evidence that SGLT2 inhibitors, dapagliflozin, has an important effect and good effect for the IgA nephropathy cases, with delaying the progression of the case and the improvement of the case at the long term. This because of SGLT2 has a lot of SGLT2 inhibitor has a lot of theoretical and clinical evidence to IgA nephropathy patients that they will get benefit from its use. There are another new therapies for the management of high-risk IgA nephropathy patients, but they are currently being evaluated. And we have a long list of drugs that must not be used. There is no good evidence for their use as antiplatelets, routine use of antiplatelets, anticoagulants for the IgA nephropathy itself, azathioprine, cyclophosphamide, calcineurin inhibitor, rituximab, fish oil. Not all of these are not recommended, and we said that MMF are recommended in the Chinese, and also the hydroxychloroquine may be recommended in the Chinese. Okay, what about IgA nephropathy with rapidly progressive glomerulonephritis? Not only pure IgA nephropathy with benign course. No, we have now IgA nephropathy with rapidly progressive glomerulonephritis. First of all, What is the definition of rapidly progressive glomerulonephritis? What is the definition of crescentic glomerulonephritis in patients with IgA? To define that the patient has IgA with rapidly progressive glomerulonephritis, crescents must be more than 50% of the glomeruli, with visible hematuria, with more than 50% decline in GFR over less than 3 months. In absence of other causes, vasculitis or whatever, I see ANCA-B, ANCA, anti-GBM, or these are negative. So to diagnose rapidly progressive glomerulonephritis in cases of IgA, crescents must be more than 50% of the glomeruli, and the patient has decline in GFR more than or equal 50% in less than 3 months with exclusion of other causes. How would we treat this case? We will treat this case with cyclophosphamide and glucocorticoids, the same as ANCA-associated vasculitis. So here the approach that we mentioned 2 slides or 3 slides before about to give only steroids or wait and see after supportive care, this is not applicable in case of rapidly progressive glomerulonephritis. In rapidly progressive glomerulonephritis, we must be aggressive in our treatment. Okay, so you have to know that crescents in the kidney biopsy doesn't always equal or doesn't always mean that the patient has rapidly progressive glomerulonephritis. It is only considered as a rapidly progressive glomerulonephritis if the crescents are for more than 50% with decline more than 50% in GFR and over in less than 3 months. Second variant of IgA is IgA with AKI. In these cases, there is a severe hematuria, visible hematuria that block the tubules, and the patient got ATN. You will treat these patients with only with supportive care and the fluids, a lot of fluids, according to his volume status. But if the patient is not responded 2 weeks, within 2 weeks, following the cessation of hematuria, you have to consider a biopsy of this patient because he may got crescentic glomerulonephritis or other cause, whatever other cause that lead to deterioration of the case. So if the case is only hematuria with blocked tubules, wait, give the patient fluids, and wait. If he didn't or she didn't respond within 2 weeks, you have to do biopsy. What about IgA nephropathy with nephrotic syndrome? Usually, in these cases, you will find effacement in the electron microscopy, and these cases will be treated as minimal change disease. Finally, an important clinical point: if your patient has nephrotic range proteinuria, but without nephrotic syndrome, this usually indicates that the patient got FSGS secondary to IgA. The patient is IgA nephropathy, then finally the case progressed and is considered as chronic glomerulonephritis, and FSGS developed. You will find proteinuria without nephrotic syndrome, and this is considered as secondary FSGS. So you will not find full nephrotic syndrome, only nephrotic range proteinuria. What about IgA vasculitis? Here the disease is not limited to the kidney. In this disease, the kidney biopsy shows IgA nephropathy, which is usually rapidly progressive, proteinuria more than 1 gram, impaired kidney function, and significant extrarenal involvement. So we have two shapes of IgA nephropathy with crescents. IgA with rapidly progressive glomerulonephritis, the condition is limited only to the kidney. And this condition, IgA vasculitis, has IgA nephropathy with crescent formation and RPGN plus extra-renal manifestations, and these cases usually treated with another immunosuppressive strategies, mainly the same as the vasculitis. And plasma exchange may have a role in these cases, especially if there is a life-threatening or organ-threatening extrarenal complication of IgA vasculitis. For sure, in these cases and for every case that presents as vasculitis, you have to assess for secondary cause and especially for malignancy. we see many cases of malignancies that presents with a vasculitis-like shape, a vasculitis-like picture, skin rash, and the final end, the case is diagnosed and the malignancy, and in some cases also of infective endocarditis. So once you have vasculitic shape, exclude secondary causes, exclude malignancy, and exclude infection, because it may be the key for diagnosis. Final point that I will say, IgA nephropathy and the pregnancy planning. If you have a female who is diagnosed as IgA nephropathy and she wants to get pregnant, you have to maximize the supportive care to decrease the proteinuria to the lowest level you can, and you can have a trial of immunosuppression to optimize immunological activity and reduce proteinuria before conception. This is preferable to emergent initiation of immunosuppression during pregnancy. So try to make the patient in remission or partial remission as possible before entering the conception period. Thank you for your watching. I hope that you liked the lecture. See you in the next lectures. Bye bye.